So you see the title, disclosures, various activities that I'm involved in with research. I do run a research laboratory, do clinical trials, but this talk really does not have any real association for support. So by way of outline, I'm going to speak to you about racial and ethnic disparities in healthcare as it relates to this topic here of sexual function outcomes after prostate cancer treatment. I'm going to give you a little bit of background so you can kind of put it all in perspective, and we're going to test the hypothesis that there's an occurrence and significance of adverse sexual dysfunction outcomes in this setting. And is it really true, myth or reality? And then some recommendations to follow. Now, when we think about health disparities, we're aware of what health disparity means: increased burden of an adverse health outcome or a health determinant within a specific subset of the population. And it can be considered along three different levels by which this may occur: patient, provider, and health system. And I'm going to speak to you kind of where we think about this perhaps in prostate cancer in a slide that follows. Now, just again, some statistics. You heard some already from David this morning, and among those who are in underrepresented minorities, African American race, you can see there really is a great disparity with respect to prostate cancer, but all health conditions. And one of the things I just wanted to bring to your attention here is if you just look at death rate for non-Hispanic blacks, non-Hispanic whites, across the spectrum, the death rate per 100,000 individual is so much greater. For cancer in general, 228 versus 191. Heart diseases, 267 versus 214. So we know there are disparities out there, and this occurs. In prostate cancer, we recognize that, and this is statistics just from this past year, 30% of all diagnoses occur in African Americans. And then among death rate, 15%. Okay, so that's much greater than what the population statistics would lead us to believe. And you can just see how that disproportion does occur. We're aware of racial variations. You've seen these slides, Siegel and all, these publications that come out regularly. The incidence of prostate cancer as a rate ratio of 1.62 for black men. Mortality rate 2.45. So really very much a significant death rate that occurs in the African American population. What are some of the factors that are involved? I mentioned this earlier, and we can think about this along the lines of disease factors, patient factors, and provider factors. And it's important to think about all of these different elements because it's not always just the patient now. It can be aspects of the provider that influences choices of treatment and the impact with regard to sexual function outcomes. Now, I actually culled the literature as best I could to look at what are some of the information, what is the information out there that might help us understand this? Well, there's evidence of treatment selection bias, that watchful waiting, shared decision making, these sorts of things which allow better information and discussion of how to proceed occurs less frequently among the African American population. There are treatment delays, although this may not occur so much across equal access centers. Lack of treatment access, health insurance, available medical facilities, and there may actually also be some systemic barriers, meaning low volume urologist centers or centers that actually have, believe it or not, hospital racial composition where the greater proportion of black patients actually may have lesser quality of service, which may not be so surprising, but that actually occurs. So these are actually literature sources that have tried to look at this topic. Why is this important? Well, I think it's important to recognize the burdens that are related to this. And there's certainly aspects of preventable physical and mental health adversity, and this can be exacted on different levels, as you can see, from education to poverty to food and even residence. But I think what is very kind of sobering to see is actually, I looked this up, Centers for Disease Control and Harvard Business Review. Would you not believe that because of health disparities, we are spending an extra $230 billion annually, $230 billion, because of lack of preventable care, dealing with patients who have complications that could otherwise have been treated in a much more upfront way. So these are very sobering statistics to realize, and I think if we address health disparities, actually we may all be saving ourselves some money in the long run. Interesting. So let's talk about sexual dysfunction disparities. Now, there's no doubt prostate cancer has effect on men, irrespective of ethnicity and race. We all would agree about that. In the African American population, some of you may know, and certainly in my clinic, I have this kind of discussion all the time, that many men, particularly of African American descent, don't want to even proceed with certain therapies because they believe that they are disproportionately affected and likely to have serious outcomes with regard to sexual function. And that perhaps counts a great deal. That counts a great deal for all of us, I think, right? I don't think any of us want to have any kind of deficiency in our sexual function. But this can influence management, and the question here is, how much does this impact decisions for care and ultimately survival outcomes because of this sort of consideration? So it's an important topic to think about. So I'm going to show you a couple of population-based studies, okay, and I'm going to try and keep it a bottom line thing so I don't wear you down with too much data. But here's a prostate cancer outcome study from CEASAR. This is a study done back in the mid-1990s, and the bottom line here is this study showed that really it seemed as though African-American men are not disproportionately predisposed to erectile dysfunction and may actually have better rates at 18 months after surgery. 38% among African Americans, 21% whites, 26% Hispanics. The extended follow-up of this study confirmed that even at now about 5 years out, there was still an appearance of better outcomes among African American men, although interestingly, it seemed to be more acceptable in non-Hispanic whites than African American men. Which is interesting. I mean, I don't think it should be acceptable for anybody, but that's what the study seemed to show. And there seemed to be no difference when there was radiation treatments. The CaPSURE database back in the mid-1990s looked at the same sort of thing. Again, another population-based study. Here, they also showed that findings suggest African American men experience a decline in function, but apparently less extensively than their counterparts. So again, another study, a population-based study that does not suggest that there is a disproportionate effect among African American men. Another study, the prostate cancer outcomes and satisfaction treatment quality assessment, prostate QUA study, I guess. This was a study back in the early 2000s. This one also showed that African American men do not experience a decline after brachytherapy, only relative to other prostate cancer treatments. So another study that suggests there's really nothing that's really different about the findings. The CEASAR study, this one more recently published, at 12 months, there was no difference in sexual function domain, and so the suggestion was, again, it does not vary dramatically between race. So all of these studies would kind of put a knock in the hypothesis. At the same time now, there have been some pretty good quality single institution studies. This is Mark Lidwin's study. This one actually did find that non-white patients are less likely to achieve a return to baseline quality of life at 1 year. And it seemed that factors that were more likely to have a better recovery is married, white, lower, and a lower educational level, surprisingly enough. So this one did show a difference. And then I just summarized on one side here some single institution studies that actually, again, contrary to the population studies, these all seem to suggest that there may be a significantly lower rate of erection recovery, that there are decreased odds of erectile function recovery. In this study, perhaps no real differences. So there seems to be contrary information out there if you look at the literature. Now, what are some of the correlates that may relate to this? Well, I think that certainly there may be some impact along the lines of psychosocial and cultural factors. And some of the studies that are out there, very few, have looked at things such as cancer-specific anxiety, which seems to be higher in non-Caucasian men, spirituality, greater in African American and Hispanic men, and it's certainly Hispanic and African American men. And, you know, it's commonly seen in the literature that they just say, put it in God's hands, whatever happens, happens. And then maybe that's a mechanism either to cope with the problem, although it may actually be the way that there may be a cultural aspect to this as well. So it's interesting to look at some of these correlates that may have to do with some of this. So how do I summarize this? This is how I summarize the evidence basis, I think, is there's conflicting evidence with regard to whether there is impact. There may be some limitations and biases across studies because there's differences across the studies in terms of study design, how they go about evaluating the patients, low numbers of African American men in studies. And there's uncertain methodologic rigor. So what does that mean? Well, some of these studies don't know about how they go about asking the question, and there's just uncertainty and low literacy in some of these studies, so that's problematic. And another point is some of these studies actually have younger men who are African American who are enrolled, and so they do actually have better function going in. So the likely conclusion is that there's an extent of sexual dysfunction effects that do not necessarily differ between ethnic groups, but the psychosocial impact may differ. So I think more studies need to be undertaken in the future. They need to be a larger number of African American men, prospective studies, culturally sensitive tools and interviews that are involved, and delve into patient-reported factors that may have a basis in bother and impact. Going forward, I think that for survivorship care, continue to enhance patient-provider communication, recognition of cultural differences, and then identify patients' psychosocial needs irrespective of their ethnicity and background. So I will stop there, and I do appreciate your attention. Thank you.